Okay. So I know that the your exams were presented in a scrambled fashion. I organized the review so that the questions kind of run a little bit more sequentially. That might help you as you go through your notes. So, um, the so I'll start with this question about a 9-week pregnant woman who complains of vaginal bleeding and cramping. A sterile speculum examination finds the cervix closed. That is the key information here, that the cervix was closed. The answer to this question, was that it is a threatened abortion. That it is threatened, not missed, not incomplete, not inevitable. So are there any questions about this question? Let's see. Okay. Okay. Preeclamptic patient on mag sulfate for 22 hours. She delivers a little girl half hour ago. What findings do you expect to observe or assess in this client? The correct answer was a boggy uterus with heavy lochia flow. Remember that magnesium relaxes the smooth muscle, and so you would anticipate, she was on magnesium for almost a full day. So you would anticipate a boggy uterus with a heavy lochia flow. So if there are questions, please let me know as we, let me just check the chat box as we are going along. All right. Okay. So this question, nurse is providing care to a patient who just learned her baby has died in utero at 26 weeks. So the priority action at this time is to ask the patient when she last felt the baby move. And the reason for that is what you're concerned about in a situation like this with you have a fetal demise. This is 26 weeks, right? So this is not the case, excuse me, of an abortion. This is a fetal demise. Your concerns are twofold: infection and DIC. And so you need to know when she last felt the baby move to get a sense of exactly how much trouble you may be in or how much trouble she may be in. Are there questions about this?
Yes. My question, would it not be more likely, like this far along in the pregnancy, that a fetal demise would be due to some sort of trauma as a result of violence, maybe?
Yeah. That's possible. But in any case, you would still need to find out, because not every situation of violence or trauma will result in a fetal demise, right? It could result in a grade 1 abruption. It could result in rupture of membranes. It could result in other things, right?
Okay.
But what you definitely need to know is what has happened, how has this impacted the fetus from the mother's perspective. And remember how much activity, fetal activity, will give you an indication of what the fetal status is.
Okay.
Okay.
Professor, so if the patient had just learned that her baby has died, I mean, wouldn't that be coming from the physician? Like, wouldn't the last movements and everything have been obtained during the assessment? Like, if we've already confirmed that the baby's died.
So she just learned that her baby died in utero. The question is, what is the next action?
Right, but to like, if the death has been confirmed, that would have been by us.
That would have been by what? I'm sorry.
That, like, well, either the nurse or the physician, whomever, would have been the one to confirm that the fetus has died. So
Right, that
the
might have
last
been
movements of
confirmed.
the baby, isn't that something that you would be asking about when you first start treating the patient?
Not necessarily. It depends on how the patient presents. It depends on how the patient presents. But if a fetus has determined, a fetal death has determined, a fetal demise has determined, you need to know when a determination has to be made as to when this occurred. So that is the information that you need to make that determination.
Professor, can you explain why you would start making that determination before contacting the clergy member?
Because so remember, what is your concern here? Your concern,
Is it infection?
concerns, because they're twofold, are infection and DIC. And I'm not saying that that spiritual support is not important, but just on your list of things to do, on your to-do list, that will take priority.
So basically, I kind of had the same thoughts that Victoria just said. So basically in the scenario, you're saying that this patient just came out of an ultrasound, they found out that her baby is dead, and
I'm saying the determination has been made. So the patient was just told that the fetus has died.
okay.
What is the next thing what is the next piece of information you would need to know?
I guess the safest possible method to expel the fetus?
Right, but you need to know you need a full picture of the situation. So you need to know whether or not this patient, what is your infection risk and what is the risk of DIC?
Would they have learned that the baby died via ultrasound, or like, I guess I'm just trying to see like how you would, I'm just trying to understand the actions that are leading up to this scenario.
So the actions that are leading up to the scenario may vary in practice, but I am saying for this question, if the patient just learned that her baby died in utero, what are your concerns? If a patient's baby has a fetal demise, patient is diagnosed with fetal demise, what are your concerns? Your concerns are infection and DIC. Those are your concerns. I'm not negating providing this patient with emotional and spiritual support. That is absolutely important. But I'm just saying that, you have to kind of prioritize it. So you want to make sure that you are establishing and maintaining physiologic stability. So if your concerns are infection and DIC, the information that you need to know is when is the last time she felt the baby move. Because did this happen yesterday? Did this happen on Friday? How much trouble are we in here?
Okay, so you're not assuming that the patient found out with the doctor. She's just coming in with this problem, and you have to, it might be an emergency situation. She might be already be at risk for infection or whatever.
She's absolutely a patient with a fetal demise or a missed abortion, either one is at risk for infection and for DIC.
And you don't necessarily have any extra information. All you know is that the fetus passed. Okay,
That the baby died.
that's clear. Thank you, Professor.
You're welcome. So this magnesium sulfate calculation, the answer was 3 grams per hour. And if I remember correctly, almost everyone, I think there might have been 1 or 2 of you that had trouble with this calculation, but pretty much everyone got this calculation correct. This one was pretty much just a straight, drop factor calculation. The answer was 50 drops per minute. A couple of you wrote in, you calculated it over an hour. And then a few of you that did that did go on to put per minute. But remember, drops per minute should be drops per minute, not drops per hour. It works out to something like 3,000 drops per hour. So however you solve it is not an issue. Just make sure that you complete the calculation all the way to drops per minute. So this was 50 drops. 50 drops per minute. Excuse me. Okay, this patient with a history of asthma is experiencing postpartum hemorrhage. As we discussed, Hemabate should not be given, as prostaglandin should not be given to patients who have asthma. Okay. This patient is suspected of having hyperemesis gravidarum. So the nurse identifies which of the following as a manifestation of this condition. The answer was urine ketones. So remember that a patient with hyperemesis gravidarum will have hydration and what we call medical starvation issues. So this patient will start to break down fat and you will see ketones in the urine. Okay. Observing a premature baby for the most common signs of infection. In a baby, remember that I mentioned in a baby, what you will see as far as temperature is temperature instability. So temperature instability and poor feeds. So this baby may have what we call medical anorexia, poor appetite, just not feeding very well, or the baby may take very little, the baby may have vomiting, may have some diarrhea, but poor feeding. So temperature instability and poor feeding are common signs of infection in a preterm baby. Okay, there were, so this question I definitely wanted to go over because there seemed to be not quite a few of you, but some of you did get this question incorrect. So the following factors places a client at risk. Which of the following factors places a client at risk for prolapsed cord? The answer, they're out of order, but the answer is A, 3 cm's 90% and -3. The high station is what makes the difference here. A fetus with a high station is at risk for prolapse cord. I noticed that many of you selected ROP, fetal position. The fetal position of ROP does not predispose this patient to a prolapse cord, but the high station does.
Professor,
Yes.
ROP, a baby in ROP, what would that do? Would that cause back labor?
Yes.
Okay.
That would definitely cause back labor.
Okay.
Definitely.
Professor, for the
Mhm.
answers 3 cm, 90% and -3, is that has to be when you perform artificial rupture of the membrane?
I'm sorry, I'm not sure I understand the question.
For the negative station,
Mhm.
you have to because it didn't say you're gonna perform the artificial rupture of the membrane.
No, but the mere fact that the fetus is at a high station is a risk factor. Even if the membranes are not ruptured artificially, even if this mom spontaneously ruptures, she is still at risk because of the high station. Any fetus at a high station like this is at risk for a prolapse cord. She's 90%, yeah, she's 90% effaced, so her labor is progressing. Her labor is progressing. With the fetus at a high station, there's definitely a risk of prolapse cord.
And also the ROP position will cause prolonged labor, right?
It can, but not necessarily. The issue is more that she will have more back labor. So how long it will depend on her full picture. So is she G1 with an ROP position, or is she G4 with an ROP position? Do you understand what I'm saying? So there's some variations there as far as the position and how long the labor will be. But the OP will definitely predispose her to back labor.
Okay.
Okay, so I think this was one of the questions that came up yesterday about postpartum patients and fever. So remember, we're looking at an elevated temperature for sepsis to be considered in the postpartum patient. We're looking at an elevated temperature of greater than, an elevated temperature after the first 24 hours. So that's the first thing, it has to be after the first 24 hours. On 2 days during that first 10 days. So which option is it? So option D, and again, they're out of order, is the one that meets that criteria. Option A, 100 degrees periodically during the first 36 hours. So it's periodically, and it's only during the first 36 hours. It's not on 2 days. 99.6 doesn't meet the criteria because it's not over 100.4. 100.8 twice in the first 24 hours doesn't meet the criteria because it's in the first 24 hours. So you're looking for after the first 24 hours on 2 days, above 100.4.
Professor,
Yes.
I have a question about this. So, But even though I know that the 24-hour has to pass, but 100.8 was, isn't it a little bit too high? Or like
It is high, but it is within the first 24 hours.
so it's
And
not
it's on 2 occasions. It's not consistent, like she was 100.8 for the entire day. That would be concerning.
oh,
It just happened twice during that first 24 hours.
so if it's consistent, we gotta take a look. But
Then, right.
oh, I missed it. Okay, thank you.
Okay, you're welcome.
Professor, for future questions regarding fever and stuff like that, should we try to see a pattern of the temperature rising? Like the second temperature, like the correct answer, in the correct answer, the second temperature will be higher than the first.
Right. But one of the, it depends, and then I'm trying to answer you broadly, not just in maternity. It will also depend on what your patient population is. So for instance, in postpartum, we're really looking at after the first 24 hours.
Right.
Whereas if you're on on a surgical ward, if that happens within the first 24 hours, you would consider it more then.
I'm just saying, if you don't mind answering, I'm just saying in general, like, I'm looking at this question, right? So I feel like I can cut out answer A and answer B right away because the temperature is not going up. Therefore, it's not as concerning.
Mm-hmm.
Am I correct in my strategy? That's what I'm asking.
So yes and no. So yes, you're certainly concerned if the temperature is escalating. If it's going up, you're definitely concerned. But a patient that has a temperature on the second day and on the 4th day, so even if it was 100.4 on the second day and 100.4 on the 4th day, not 100.8, but 100, you would still be concerned.
Yeah.
So it's both things. It's the timing and it's the escalation.
Right. I would look at the timing as well. I'm just asking, like, just in general, like, just as a test taking strategy in order to, remove, answers that I know are not correct quickly. That's okay. Thank you. Thank you.
A question. That's why this is, for me at least, because we said that the first day the mom postpartum may have high temperature, which is normal, and then we look after 24 hours. So even the C would have been, let's say, possible, or you want to see over starting.
Remember, from a test taking standpoint, if you have an answer option that has 2 parts to it, like C, both parts have to be true for the answer to be correct.
Because you cannot have a 99.6 on the first day.
Right.
No?
No, that would be considered to be more a matter of hydration status.
Yeah, exactly.
So that's why that option would not be correct.
Okay.
Okay. Okay. So this patient, I think you had to think about what is going on with this patient. So first of all, the patient has polyhydramnios. So there's some concerns right there. All right. Her membranes rupture. The fluid is clear and odorless, which is good. But then the fetal heart monitor indicates fetal bradycardia and variable decelerations. So what happened? Just based on that, what happened?
The cord
compression.
Yeah.
It's cord compression. So what's causing the cord compression? What type of cord compression would you think it is?
Prolapse.
Yeah, it is
No,
a prolapse cord. this is a prolapsed cord. So how are you going to determine that it's a prolapsed cord?
Vaginal exam.
Right. You have to do a vaginal exam to see if you can, if you can palpate the cord or possibly elevate the fetal part that is compressing the cord. So the correct answer was perform a sterile vaginal exam. Okay, a barrier to healthcare for adolescent moms. The correct answer was A, that the teen will see a different nurse and or physician at every visit, which is pretty much a barrier for any of us. If we go to wherever we receive our healthcare services, if we have to see a different person every time, that's not going to make us more inclined to keep going back. Okay, overhydration in preterm newborns. So this question drew on some things that we've talked about preterms, and also on some things we talked about throughout the semester, but also on some of your fundamentals knowledge about hydration status. So a patient that's overhydrated, a vulnerable patient like a preterm baby, you will hear rales or crackles. This baby will be edematous, and that is just the retained fluid. Patient will not have poor tissue turgor. You would see poor tissue turgor in a patient that is dehydrated. Yes, you will have a specific gravity less than 1004. Remember, the urine is going to be dilute. Urinary output of less than 1 ml per kilo per hour. No, you will not have that. So not F. If anything, you would have urinary output, a higher urinary output. Increased weight gain, yes, from the retained fluid. And this patient will not have depressed fontanelles. You would see that in dehydration. If anything, this baby would have bulging fontanelles.
Yeah. So Professor, question, the values on the urine specificity are equal either for the grown-ups than the babies? Because unfortunately, yes. I didn't remember the 1.0053 up to 1.0030. I remember 1.003 as a minimum and normal, so I considered that normal, unfortunately. But yeah, so the value are for as well as the grown-ups, the specific
for specific gravity.
All right. Thanks.
Oh. So this calculation, the answer was 2 mLs. I'm just looking at my notes to see. Okay, there were no questions about this. I think everybody got this one correct. Okay, so a patient with acute pyelonephritis is receiving IV fluids and antibiotics. So remember that pyelonephritis, these patients can, and very often will have repeat episodes of pyelonephritis. If pyelonephritis is not treated and treated aggressively and completely treated, it can advance to maternal sepsis. So remember that any type of infection can lead to preterm labor, as well as rupture of membranes. So the question is asking, the nurse determines that the client needs further instruction when she says that acute pyelonephritis can lead to which of the following? The answer was congenital fetal anomalies. Pyelonephritis will not lead to congenital fetal anomalies, but again, it can cause maternal sepsis, preterm labor, recurrent infection. It can also cause rupture of membranes.
And Professor, sorry, congenital is from genetics. So an
Basically,
infection.
yeah.
I have a question about the pyelonephritis. The nephrostomy can be performed on a pregnant woman, right?
It
Like
can
really
be if
fast?
it needs, yeah, if it needed to be done, it could be done.
Okay.
Oops. I don't know why that happened. Okay, most women with gestational diabetes develop type 2 diabetes in the postpartum period. Is the statement true or false? The statement is false.
Okay.
Most women with gestational diabetes will go on to develop type 2, but not in the postpartum period. So it might happen as late as 15 to 20 years later. And up to 60% of these women, 60, 70% of these women will develop type 2, but not in the postpartum period. Okay, nursing diagnoses for the patient with congenital diaphragmatic hernia. So which of these diagnoses is of the highest priority? So for this patient, all of them are applicable. But in terms of priority, it's basically based on your ABCs and what is the main issue for this, for a baby with diaphragmatic hernia, and it is the baby's respiratory status. So the correct answer was D, ineffective breathing pattern related to structural anomaly. Okay. Okay, so this patient, 34 weeks with premature rupture of membranes, test positive for GBS. So, so just reading that, what is the priority? You're concerned about this preterm baby being exposed to GBS during delivery. The patient's contracting, her vital signs are indicative of well, let me not say that. Sorry. All right, so patient like this, she's 34 weeks, you would expect the physician to order penicillin to treat the GBS. Yes, she is 34 weeks, but in terms of priority order and what you need to address, the infection is going to take priority over administering betamethasone. I did notice that several of you selected the betamethasone option, but treating the GBS is going to take priority over that, over fetal lung maturity because this baby is 34 weeks. So this is not like it's a 28-weeker.
Professor, I have a question.
Mhm.
During the class, when we are talking about the betamethasone, don't we talk about, oh, particularly this medication we're going to do to buy some time in order to go to a good clinic or maybe for the infection treatment or for...
Mhm.
Yes.
So yeah, betamethasone will accelerate fetal lung maturity. But what I'm saying to you is this is a mom, so you have to, looking at the full picture, this is a mom who is 34 weeks gestation. She is contracting 4 to 5 every 4 to 6 minutes. I think the question said every 4 to 6 minutes. So the chances are she is going to deliver.
Can I, if you don't mind, can I go back to the question, please, just to see?
She is going to deliver. I don't think I'm going to be able to go back easily. This mom is going to go out. I'll go back. I can go back after, but I can't go back right now. I'll have to go out and come back in. But my point is this. The priority for this mom who is going to deliver is to address the risk of infection as opposed to the fetal lung maturity, because the betamethasone, even though you give it, it's going to take a little while for that to be effective. I'll come out and go back to the question
Thank you. It's fine.
so that you can see it.
Professor,
Yes.
is to prevent the early onset of sepsis in the newborn?
Right. Because remember, the mom is GBS positive.
Yeah. And because the sepsis in a newborn, the early onset will be more fatal than something developed later.
Correct. And also because the baby is preterm. So the baby will be very vulnerable.
Okay.
Professor, the baby can cut the GBS through the vaginal delivery or when the baby is still in the uterus?
So typically our main concern is with vaginal delivery, but remember that GBS will ascend, particularly if the operculum is dislodged or if the membranes have ruptured.
Oh, okay, thank you.
The bacteria will ascend. I think that was one more. Almost there. Just gotta click through. Wait a minute. I have to display it differently. The questions are now scrambling.
Priority, like what will be more fatal to this infant? Because 34 weeks.
Mm-hmm. Yeah.
But the penicillin, the GBS is probably more fatal, and then the immature lungs we could probably treat with surfactant and all these other things that can be done.
Right. So yes, you are prioritizing in two ways. So yes, prioritizing what is going to cause more harm at this point, and which one in terms of your treatment is going to be most effective. So you can treat the infection much more effectively than you can right now addressing the lung immaturity. If you give betamethasone, it is going to take time to take effect, much longer to take effect than the penicillin. So the priority here is treating the infection, then would be addressing the lung maturity issue. So Nurizanat, I don't know if this answers your question.
Yeah.
Yeah, that's fine. But in general, even if it's not the infection issue, if we give betamethasone, what's the administration time? I mean, like Rogam is 72 hours, right? So if the question is about betamethasone, what's the time? Is it possible for you to tell me, please?
So, well, Rogam we need to give within 72 hours of the delivery. Betamethasone we are giving
Intrapartum.
Yeah, we're giving it intrapartum, but we're giving it either Q12 or Q24, depending on, you know, what the preference is given the situation. But we're giving the betamethasone, but remember you need a couple of doses before it takes effect. So it's going to take a couple of days for it to take effect. Whereas penicillin, you can get more penicillin in and get to a therapeutic level faster than you can with the betamethasone, with the steroids. So as soon as the patient comes in, you can start either or both. You can start penicillin, you can start betamethasone. So it's not that you have to wait or there's a certain limit on the time. The question is, which one is going to be most effective to address the major problem? And the major problem in this situation is infection.
Professor,
Yes.
just to rule out all the options, the woman is already in labor, so we will never give a methergine to relax the contraction, do we?
But methergine would cause the uterus to contract more.
Oh, okay.
Right. So there's no reason to give this. She's already contracting every 4 to 6 minutes.
Yeah.
I mean, more than likely, this is a
Few hours later, she's gonna.
Yeah, it doesn't tell you what the stem didn't give you an idea of the cervical dilation, but this baby more than likely is going to be delivered, right? But there's no reason to give methergine. And to treat the GBS, you want to give penicillin, not gentamicin. So I don't know why the questions are kind of out of order, but let me just see. Yeah, they're way out of order. Okay. All right. Yep. Patient. Okay, so this cardiac patient, what are you observing in terms of signs of cardiac decompensation? The answer was D. Dyspnea, so difficulty with breathing, crackles or rails. From pulmonary edema, and an irregular weak pulse. That was the correct answer. I noticed that a few of you did answer shortness of breath, bradycardia, and hypertension. You wouldn't necessarily see hypertension. What you would see in terms of decompensation is an irregular weak pulse, as the heart is overtaxed with the work. It's going to become weaker, and then fluid is going to back up into the lungs, which is why you will have rales or crackles and difficulty with the breathing.
Professor,
What is decompensation like really mean?
Decompensation, so getting worse. Her cardiac status is getting worse.
Oh.
So the heart is being overworked and getting, not able to keep up with the demand.
So, Professor, so decompensation is an indication when a person is going into congestive heart failure?
Yes, you can see that.
Right.
Decompensation when the patient's developing congestive heart failure, or the congestive heart failure is getting worse.
Okay.
Thank you.
Professor, if answer C was only shortness of breath and bradycardia, would it be correct?
Shortness of breath, yes. Bradycardia. So bradycardia is saying that the heart rate is slower. Bradycardia is the heart rate is slowing down. But what you have with cardiac decompensation is the heart might not slow down. It's not that it's slowing down, it's just not working as effectively. So the pulse is weaker, not slower. So the rate may be fine, but it's not pumping effectively.
Okay, thank
you.
you.
I would not say bradycardia, okay?
So the answer is D?
The answer was D, dyspnea, crackles, and irregular weak pulse. Okay. Okay, this one we did. Again, they're all scrambled up. Give me in the right order. This one we talked about already. HT we did. Okay, retinopathy of prematurity. So we talked about this a little bit in terms of the fragility of the blood vessels of the eye and ensuring that we're giving the patient, giving the baby enough oxygen for the brain function, but keeping it at a minimal amount so as not to impact the blood vessels of the eyes. So the correct answer was careful monitoring of oxygen administration. Maintaining an oxygen saturation of 98 to 100 means that you are giving a lot of oxygen. So the correct answer was careful monitoring of oxygen administration. Retinopathy of prematurity is not caused by exposure to phototherapy, to the lights that are used for phototherapy, and suctioning doesn't really impact on this. So information that the nurse should endorse to the nurse on the next shift regarding a patient with preeclampsia. So the correct answer was D, right upper quadrant pain, which tells you that the liver is becoming involved, which means the patient might be developing HELP. The situation is getting worse. Hourly urine output from 400 mils to 300 mils is fine. She's still at 300. We certainly wouldn't want to see her go below that, but she's still within normal limits, so that's fine. Blood pressure of 150 over 90 is to be expected for a patient with preeclampsia, and a respiratory rate of 18 is normal. So intrauterine pressure catheter, an intrauterine pressure catheter is ordered for a laboring patient with a hypotonic labor pattern. So IUPCs are placed to get a more accurate reading of uterine activity. So the correct answer was B, accurately monitor uterine activity. Oh, this one we did. So, what should the nurse teach the parents of a newborn with a congenital heart defect? So remember that signs and symptoms of a congenital heart defect are very similar to those of respiratory distress. So the answer was A, observe the infant for signs of respiratory difficulty. Weeks. Setting sun. Sunsetting of the eyes is observed in hydrocephaly. So remember, we looked at those pictures of the babies with hydrocephaly, the excess cerebral spinal fluid, and the pressure, the intracranial pressure, is what causes the eyes to rotate downward, sunsetting of the eyes. If a patient is admitted with a suspected placenta previa, the first thing we need to obtain is an ultrasound to ascertain where the structures are, where's the placenta, is it intact or not, and exactly where is it in relationship to the cervical os. So we certainly would not want to determine cervical dilation and effacement assessing the cervix presents a risk of rupturing the placenta. So the answer was A, determining cervical dilation and effacement. Babies whose mothers are substance abusers frequently exhibit, where's the answer? D, decreased amounts of sleep, a hyperactive Moro reflex, and difficulty feeding.
Professor, quick question in regards to that. So when it's alcohol abuse, you see the withdrawal much more, what is it, like 3 hours after the baby is born, as opposed to substance abuse? It takes a little while, right?
It can take longer with, it can take longer with opiates. Yeah, with narcotics, sometimes with stimulants like cocaine are a little bit faster, but I would say in terms of what you will see first, probably alcohol, then your central nervous system stimulants like cocaine, amphetamines, and so on, and then your narcotics.
Okay, thank you.
Let me just see if I have a response. Oh, sorry. Just want to see if there's a response from Professor. Yeah, okay. No answer to the HESI questions as yet. Okay. Which client situation presents greatest risk for the occurrence of hypotonic? So hypotonic dysfunction. The answer is D, a multiparous client. So this is a client whose uterus has been stretched several times at 39 weeks. So she is term, so it's stretched, and she is expecting twins. So it is really stretched. So that is a uterus that is not going to contract. The muscle has just been so stretched, it's not going to contract as effectively as any of the other options. Okay, that one we did. Really all mixed up. The three most common causes of postpartum hemorrhage are A, lacerations, uterine atony, and retained placenta. Those are the three most common. The other, excuse me, the other options have correct parts in them, but none of them are completely correct. Okay, that one we did, diaphragmatic hernia. So post-term infants, a post-term infant who weighs 3630. So right there, that baby is somewhere around 7 pounds. So a post-term baby that weighs about 7 pounds has more than likely lost weight in utero. The baby will not have soft and supple skin. The skin will be very leathery and thick kind of tough, leathery. Hematocrit of 45. No, this post-term baby will have a higher hematocrit. Remember, from the diminished oxygen due to the placenta degenerating. An abundance of vernix caseosa. No, this baby will have a very small amount, if any, but the baby will have a lack of subcutaneous fat. So the correct answer was C, lack of subcutaneous fat. All right, so this patient is having a dysfunctional labor pattern and is undergoing labor augmentation. She's currently having regular contractions. 30 to 60 seconds is relatively short. Every 4 to 5 minutes is not very frequent. The fetal heart tracing reveals occasional early decelerations, which are normal. Infrequent accelerations, which are normal. So this patient could tolerate having the oxytocin increased according to protocol. Increased according to protocol.
Professor, why not maintaining the, I mean, she was doing great.
Well, I wouldn't say she's doing great because
the baby,
the contractions are only 30 to 60 seconds every 4 to 5 minutes. So that we're not really moving along.
Oh, okay, you increase to move on because the baby is not suffering. I mean, the fetal rate, it's okay.
Right.
So they can
Baby is
accelerate.
stable.
Okay.
Right. The baby's tolerating this, so we can advance.
All right. Okay.
Move this along.
Okay.
So
Okay.
I'm completely confused by this question.
Okay.
The fetal heart tracing reveals occasional decelerations and
early decelerations.
So that's normal.
Those are normal, right?
No, but it says occasional and then infrequent acceleration. So to me, that's variability.
No. What's an acceleration?
An acceleration.
The fetal heart rate increases, right? If the baby's wiggling, the baby moves around, the baby starts kicking, the fetal heart rate increases.
Not in line with the contractions. Right? Like they are abnormal, the accelerations are abnormal, right?
Accelerations are normal. You will see accelerations in response to fetal movement.
So the fetal heart tracing is completely normal.
Correct.
And her contractions, 30 to 60 seconds every 4 to 5 minutes. That sounds normal, but then it says she has a dysfunctional labor pattern.
Has a dysfunctional labor pattern. That is why we're doing, right. She has a dysfunctional labor pattern. So she's undergoing labor augmentation to help this dysfunctional labor pattern be more effective.
What is
That's why you augment the labor, right? To make it more effective.
So what is dysfunctional? I don't understand what is dysfunctional here.
Her labor pattern, without the augmentation, without the help, her labor pattern would be dysfunctional. So we are augmenting it to get it to be more functional, more effective.
Okay.
So you want to see late deceleration?
You don't want to see, you never want to see late decelerations. What you want to see are contractions. So the contractions that she's having are moderate to firm, 30 to 60 seconds, which are short, every 4 to 5 minutes. So she's not really contracting very much. If we are augmenting, we're trying to help this process along, to move this process forward, then we need to give more oxytocin to move this along. We're not really getting anywhere right now. The fetus is tolerating, the fetus is fine, but we're not moving forward. We're not getting closer to the delivery, which is why you would increase the oxytocin.
So Professor, from what I recall, it was we don't want them lasting more than 90 or 120 seconds, right?
Yeah.
So since the baby is tolerating this and we're not moving along and we want progress, but as long as the baby is tolerating, we could increase.
Correct.
Okay.
Professor,
We can-
I'm still confused because I'm almost sure that 30 to 60 seconds and 4 to 5 minutes was normal. It's not.
I'm not saying it's not normal. What I'm saying is we are trying, our goal here is to help her deliver, right?
Oh,
But the contractions at this point, we're not going anywhere. She's just contracting and contracting and contracting. We're not getting closer to the delivery. If our goal in augmenting is to help the labor be more effective and more productive, then we need to push this along. So we need to increase.
okay. So the
The
question.
baby's okay. The baby's tolerating, so we can increase.
Okay.
So
Now I got
Professor,
it
if it were to be that the baby's not tolerating it and that the contractions are lasting longer, then we want to decrease.
Correct.
Okay.
Correct.
This baby's fine. The contractions are, we want to get this going.
Right.
Okay.
Right.
So Professor, the problem here we see is that the contraction is occurring every 4 to 5 minutes. That's why we are increasing the.
Right. And they are 30 to 60 seconds. So they're not that long. And the intensity is moderate to firm.
I don't get the moderate to firm intensity.
They're not that, how can I say this? The uterus is not contracting very firmly. So it's contracting, but not tight. The muscle is not getting really firm.
Okay. Thanks.
So what you want to see, you want to make your way to contractions that are more firm intensity. Okay.
Mm-hmm. Yeah.
So contractions that are longer and or contractions that are happening a bit more frequently and that are more intense are going to move this process forward. But if we leave her here, she'll just be in labor. You know what I mean? This baby's we're not moving anywhere.
This was a tricky one, Professor.
Yeah, it was not so obvious. I mean, probably we didn't cover in depth, or we never saw in clinical.
Right. This is, yeah, but this
I
is.
don't know. I mean, I personally, honestly, I didn't. That's why I maintain, because I said they look like fine, both mom and baby. So I maintain the oxytocin.
Right. But if we're augmenting her, we should be making it more effective. That's the goal of us augmenting.
And then
right?
Professor, when we think of, I was trying to think about this one. If she stays too long, like if her labor lasts long, if she has a dystocia labor, it's not good either, right? So that's why we want to get this going. Okay.
Right. Okay. Oh, this one we did. Just realized that. So loss of a baby, a woman tells the nurse that her husband didn't cry, hasn't expressed any sadness. She feels that he never really wanted this baby. So what is the most appropriate nursing response? The correct answer is C, the option that's listed at the top here. Each person mourns in his own way and according to his own timetable, which is true for all of us. So that's the correct answer there.
So what's the meaning of own timetable?
And in his own time. So for some people, they might cry immediately when a death happens. They might cry that day. Some people might cry a week later. Some people don't cry for a couple of months. Everyone, you kind of experience grief on your own timetable, your own, kind of your own schedule.
And
To
is
put it.
why not the D? You ought to confront him and see what he what his
feelings are. So the issue with what makes this not the correct option is to confront him. It's one thing if you're saying you're going to have a, you want to have a conversation with him, or you want to talk to him, or try to encourage him to express his feelings. But if you want to confront him, you ought to confront him. First of all, you ought to is a directive. So you're telling her to do something, and then you're telling her to confront him, which is not
but it's
the
not
approach.
me as the nursing doing the confrontation, is his wife, and his wife can do that, right? Like what's going on with him. And
You don't want to encourage a confrontation. You might want to encourage a conversation. So you could say to her, talk to him, encourage him to express his feelings. That you could say. Excuse me. That you could say.
okay,
Encourage him to
confrontation.
express his feelings, but for him to confront him
Okay.
and see what his feelings are is a different tone.
Okay, I get this one. So the conversation in this line, it makes it correct. At the same way, number C, which is the timetable, it makes me a sense like, oh, that person gonna cry at night, that person gonna cry at, I mean, timetable, it doesn't make, I mean, to me, I'm not saying, I'm saying it to me, like the person gonna cry on according to his timetable, it doesn't, even if I say it, it doesn't, I mean, kind of not, I don't get it.
So the first one is simply saying everyone, and it's true for every one of us, everyone grieves and mourns in their own way. When faced with the death, we all handle that differently.
I understand to on way up to this, but and according to his own timetable.
According to his own timetable. So we're all at different stages in our psycho-emotional development. So depending on wherever we are, that is how we will experience the grief. So it's according to, basically saying according to your own personal schedule, where you are in your emotional life, where you are in your emotional development. Do you understand, or you have further questions?
No, I do understand. Thank you. I think that's not my level. I mean, I really don't get it. I mean, I understand your explanation, but the wording, because and according to his own timetable, that's the reason I didn't choose it, because I understand up to that point, but according to his own timetable, that's the only one reason. Again, confront, I get that explanation because I don't know the meaning of confront by that time, like it's so, right? Okay, it's fine. Thank you.
Okay, penicillin. So there seemed to be a little bit of confusion. Look at my notes about this, how this was calculated. A couple of you got this incorrect. So what I noticed is a few of you, instead of giving the dosage amount, how much it should be, the calculation comes to 3.2 mLs per dose. Instead of giving 3.2 mLs per dose, that was multiplied by 4, and the patient received 12.8 mLs per dose. So what you ended up doing was giving the full day's amount of medication in one dose. And I think that's because of the Q6. That there seems to be some confusion about that. The order is written and it is telling you to give 200,000 units per kilogram per day. Right. but you're giving that is how much you're giving per day, but you're giving it every 6 hours. So you need to divide that amount by 4. So the answer was 3.2 mLs per dose. One or two of you did had 3 mLs per dose. I'm not sure if that was because of rounding. Remember I said the amounts shouldn't be rounded. And I think one or two of you had 3.18, and I think that's just how the calculations, a difference in how the calculations were done. All right.
So Professor, did we get point when we had 3.18?
I think technically it equates to the same, so credit was given, but just be careful with that, because it would equate to the same thing. So credit was given for that.
Okay, thank you.
Okay. Did we do this one already? Oh, no, we did not. Okay, so patient who is receiving magnesium sulfate at 1 gram per hour after a loading dose for preterm labor looks flushed, complains of feeling warm. So the question is, why is she feeling this way? That is the question. Why is she feeling this way? Flushed, warm, agitated, thirst, those are all side effects of magnesium. So the nurse's initial reaction of these options should be to reassure the client that this is a normal response. And your actual interventions further than that are basic comfort measures. These are side effects of the medication.
Professor, on your PowerPoint, it said that flushed was a sign of toxicity.
I will go back and look at it. But this is a patient, does it say flushed and feeling warm, or does it say just flushed? I will go back.
It said diaphoresis and flushed.
This patient isn't diaphoretic. I'll go back and look at it, but those are flushed, feeling warm. Flushed and feeling warm are normal signs of magnesium infusion, of a magnesium infusion.
Flushed wouldn't be a sign of toxicity.
Not this situation, no. But as I said, I will go back and look. I'll go back and look at the PowerPoint.
Okay.
So a patient with sickle cell. Signs and symptoms of sickle cell crises include fever and pain. Fever and pain. Patients with sickle cell are actually not typically anemic, but fever and pain. Okay, mastitis, when information with the nurse recognizes contributing to mastitis in the breastfeeding mother. This was a multiple response question. So supplemental feedings is one. If she is supplementing breastfeeding with bottle feeding, that can contribute to mastitis. Blisters on both nipples and insufficient emptying. Insufficient emptying is going to be the primary thing, really, that is going to contribute to mastitis.
So it's 2 or 3?
Question?
It's insufficient emptying, blisters on both nipples, and that's it? Or
And supplemental
supplemental.
feedings.
Okay.
Supplemental feedings, because the supplemental feedings will actually contributes to insufficient emptying. if the baby's being offered a bottle and formula, the baby's not going to feed as effectively at the breast. No, not every time, but it contributes. It can contribute to mastitis.
Supplemental feedings means
Oh.
bottle feedings.
Yes.
Okay.
So which of these clients is at risk for primary, which is early postpartum hemorrhage? And the correct answer is B, a woman with severe preeclampsia on magnesium sulfate whose labor is being induced. So the magnesium sulfate will contribute to relaxation of the uterus. And then the induction, the pharmacologic manipulation of the muscle will contribute to the muscle being flaccid after the delivery. Where's my, okay. This one we did. Pyelonephritis we talked about. That one we did. Okay, this one we didn't do. Okay. Prima gravida. So this mom is G1. She's 40 weeks. She is having contractions every 1.5 to 2 minutes. She says they're very painful. Cervix is 2 cms dilated and has not changed in 3 hours. With contractions that frequent, there should be some cervical change. She's crying and wants an epidural. What is the likely status of her labor? Given that the contractions are still frequent and not contributing to cervical dilation, and she's saying that they are very painful, the answer is C. She is exhibiting hypertonic uterine dysfunction. "10 weeks, and a suspicion of hydatiform mole." The answer is C, fundal height of 18 cms. Remember that with hydatiform mole, the fundal height will be much higher than it should be given the gestational age. This one we talked about already, postpartum temps. Okay. So night shift nurse, she gets a call from a patient who was discharged who had her baby last night. Fast labor, early discharge. Now the mom is saying she has really bad pain in her bottom with a lot of pressure, a lot of vaginal pressure that is getting worse. She took pain, something for the pain. It doesn't help at all. So more than likely, given that she had such a rapid labor, very fast labor, she more than likely is still bleeding internally. So she's probably got a deeply internal laceration, and the pressure is coming from hematoma formation. So the correct answer was A, a hematoma may be forming. Notify your physician about these symptoms tonight. If she had retained placental fragments, her uterus might be firm, but we wouldn't ask a patient who's recently discharged if her uterus is firm. But even if you do the retained placental fragments, her complaint would be more of heavy lochial flow, as opposed to pain and pressure,
And it's
internal pain and pressure.
It will not happen few days later.
You can have heavy lochial flow from retained placental fragments early on as well.
Okay.
You usually see it later, but you can see it early on as well.
But for the hematoma, it's not bleeding, right? It's bleeding inside the tissue.
Correct. And that is why she's having this pain internally and a lot of pressure, vaginal pressure, that is getting worse.
Oh, so
this is the bleeding into the soft tissues internally, right?
Okay.
Can you just clarify, why would we tell her to notify the physician, and why would we tell her to wait until that night versus us notifying the physician and the physician being notified sooner?
So this is a mom who was discharged home, and she's calling back to the hospital to say that this is what's happening. She's at home.
Yeah, and I get
so
that.
You could tell her to come in, but that's not an option here. So for us to call the physician, for her to call the physician is a lot faster than for us to call the physician to say, you know, Jane Doe is having whatever problem. You tell the patient to call the physician, because the physician is going to tell her exactly what the physician wants her to do, as opposed to we call the physician tells us what to tell the patient, and then we have to call the patient back. Do you understand what I'm saying? It's another step.
Right, no, I get that, but I guess I just was confused because it says the nurse is working the 11 p.m. to 7 a.m. shift. It doesn't, I mean, the patient could be calling at 6, or we could be on the phone with the patient at 5 a.m. So the whole calling them tonight didn't make sense to me. So it really should just be that she should be notifying the physician immediately. It just wasn't clear. Okay, thanks.
I have the same issue on that one.
That's basically what it's saying, though. She should call the physician tonight. Patient diagnosed with an intact tubal pregnancy. What is the priority? The priority is administration of methotrexate. So again, the tube is intact. Administering the methotrexate will diminish the products of conception and save that fallopian tube.
I'm sorry, I got that. I was, but the priority, since it's intact, don't you say that we need to, like, always the informed consent, and we need to explain? I mean, it's not an emergency. You administer, but you explain before what she will expect, no? The side effect, no?
Yeah, you would explain that.
Because it's intact, there's no emergency right now. I mean, I'm wrong probably, but
no, I wouldn't put it that way, but it's intact, but I wouldn't say that there's no emergency. I mean, it's intact as opposed to it's ruptured. Yes, there's a difference in terms of emergency.
You are explaining the treatment plan. You are gonna say, I'm gonna administer this is gonna do on your tubal pregnancy and blah, blah, blah. Okay, I don't know. I mean,
so is the question is, I guess what you're asking is the priority explaining or is the priority administering?
I saw me in the hospital explaining to the patient, I'm going to administer this because, and you have to expect that. Like you have to do an informed consent. But probably I'm wrong. I mean, I'm wrong. I will administer the meds.
I see your point, but the priority would be to treat it, to make sure that you address this before the rupture. But I do see your points. This one we discussed already.
So for these types of questions, because I see what Simona is saying, and I was thinking the same thing. So the priority would always be address the physical issue that's going on.
In that situation, yes, because the tube is intact right now.
Exactly.
Right, but it could rupture.
It could rupture
at any moment. That's why we have to take care of the problem first. That's why it's the most important thing for us to do, even though everything else has to be done.
Has to be done, right?
Thank you.
So here we have a 29-weeker, 29-weeker, presents, says she's having contractions every 8 minutes. Her cervix is 3 cms dilated. Which of the following should the nurse expect to administer? So certainly IV fluids. We want to keep this patient hydrated, and to minimize the impact of dehydration possibly contributing to this preterm labor. So certainly IV fluids. We would give terbutaline as a tocolytic. She's 29 weeks, so we would give betamethasone. So those are the 3 that we would do. There's no indication that RhoGAM is needed. There's no indication to give folic acid or to give Nubain for pain management. Okay, so this patient is a smoker. She smoked throughout the pregnancy. She presents at 30 weeks. Fundal height measurements are suggestive of intrauterine growth restriction. In addition to an ultrasound to measure fetal size, which of the following will be most useful in confirming the diagnosis? So the concern here is growth restriction related to her smoking throughout the pregnancy. The correct answer is a Doppler flow analysis. The Doppler flow analysis will give you an indication of blood flow through the umbilical cord, so you know how much, it gives you a sense of how much oxygen, how much glucose this fetus is actually getting, or not getting in this case. So the answer was a Doppler flow analysis.
Why not D, daily fetal movement count?
So a daily fetal movement counts will give you an idea of fetal activity. That will give you, yes, an idea of how much well, let me not say how much. It will give you an idea of if this fetus is getting adequate oxygenation, but the question is asking you which will be the most useful to confirm the diagnosis. The Doppler flow analysis is going to give you a better idea of the blood flow, of the actual blood flow, oxygenation, as opposed to the kick counts.
In
The
general,
Doppler flow is going to give you more specific, detailed information.
yeah, but isn't that we're gonna do a little bit later, because first we're gonna go from little by little, because we're gonna do the, I mean, if the mom is smoker, obviously the baby not gonna go get enough oxygen. The placenta not gonna perfuse it well enough.
Right.
So baby gonna
And
move
that's,
less. So then we're gonna go when the patient gonna report like, oh, my baby is moving less. It's less than 4 times in 1 hour, less than 10 movements in 2 hours. Then we're gonna go for the Doppler. Then she's gonna come in the hospital, and then we're gonna go the Doppler. We're not gonna go for the Doppler at the beginning, right?
so she's presenting at 30 weeks. Remember, she has smoked throughout the pregnancy. So this fetus has been, has had diminished oxygen throughout the pregnancy. So it's not actually that the oxygen level is suddenly going to diminish. You're not really going to see a change because she smoked throughout the pregnancy. So this fetus, whatever the activity is, it's the same throughout the pregnancy because she smoked throughout the pregnancy. So you're not necessarily seeing a change, but you do an ultrasound to assess fetal size. The Doppler blood flow analysis is going to tell you just what you mentioned, how restricted is the blood flow that is coming, going through the placenta. That is exactly what the Doppler blood flow analysis is going to tell you. It's going to give you much more accurate information about oxygenation to this fetus than the kick counts. And it's giving you objective information, not the mom's perception of fetal movement. It's giving you an actual measurement of blood flow through this placenta.
But what's the first thing?
What is the first thing? The first thing is the ultrasound. And the second thing would be the Doppler blood flow analysis. The ultrasound would be the first thing.
So the patient never gonna tell or inform or report about the less movement of the baby, never, right?
That would be something that we would have the patient do, yes, but that would be on your list of things that you're using to diagnose growth restriction due to smoking. Fetal kick counts are going to be lower on the list than the Doppler blood flow analysis.
Okay, get it. Thank you, Professor.
You're welcome.
Professor, why not C?
The amniocentesis is going to give you information about more about chromosomes, about neural tube defects. It's not going to give you an idea about the oxygenation status.
Couldn't you use that to assess for fetal lung maturity?
You do, but what you're assessing is when you do an amniocentesis to assess for fetal lung maturity, what you're testing for are specific byproducts from surfactant.
Oh,
So it's a
okay.
different process.
Okay, thank you.
Okay? Yeah. This one we did already. So we're working on a teaching plan for a type 1 diabetic, pregnant type 1 diabetic. What should be included in the plan? Insulin requirements. So she's a type 1 diabetic. So she's already on insulin. We should tell her that her insulin requirements will increase as the pregnancy progresses. Because remember, as the placenta is developed and matures, it will churn out more hormones, and the increase in hormones will increase the that insulin antagonist activity. So the answer was insulin requirements will increase as the pregnancy progresses. This one we did already.
Professor,
Yes.
for the previous question, I thought that the insulin requirements went down in the beginning of the pregnancy.
She's a type 1 diabetic.
She's already on the insulin.
She's a type
Oh.
1 diabetic.
For
Mhm.
type 1, it's going to go up.
So it increases as the pregnancy progresses. We're not just talking about at the beginning, but as the pregnancy progresses, her insulin requirements will increase.
So it's going to go down and then up.
So for a type 1 diabetic, more than likely it's going to basically stay the same initially, and then it's going to increase.
So for what patients does it go down and then up?
So typically more you will see, I don't know that I would say it would go down, but it's that the body frees up more glucose for the fetus. So in general, for all patients, that happens for all patients. So the needs initially don't really make much of a change. It's as the pregnancy progresses, as the placenta grows and matures, the insulin needs increase. And that's true for everyone. Insulin needs increase as the pregnancy progresses. The question is just, is the patient able to produce that insulin or not? A type 1 is not able to produce that insulin, so she's going to need more insulin as the pregnancy goes forward.
Okay, I had recalled you saying something about the insulin needs becoming less through the first 3
That might be in the first trimester, but as the pregnancy progresses, the insulin needs will increase.
Okay, yes. So what I'm trying to understand is for the first trimester, is that true of everybody that's on insulin or just certain diabetic patients?
So type 1s typically they might diminish slightly, but they typically will stay pretty much where they were. There might be a slight decrease because your type 1s, remember their needs are different. They're really not producing anything.
Okay.
Okay.
And it'll be the same for type 2?
For type 2s,
Well, they're not taking insulin.
They might not be. Type 2s might not be. They might be diet controlled. That's the thing.
Okay.
Not every type 2 is on insulin.
Okay, thank you.
You're welcome.
But due to that previous question,
Just a question.
you skipped the 41. You just one we just did. You didn't go over it.
41.
Yeah.
The NPO, yeah, the 32 weeks neonate NPO. But you
About the breast pump.
The breast pump, what she
So you know
said.
what? I'll go back to it. We're at 42, so let me go forward and then I'll go back because
Okay.
it's gonna. If I go back, it's gonna re-scramble and I'll have to go through all of them again. So let me get to 50 and then I'll go back to that one. Factors that contribute to development of placental abruption. So crack cocaine use, yes. Advanced maternal age, yes. Hypertensive disorders, yes. Use of antihistamines, no. Cigarette smoking, yes. Advanced paternal age, no. This one we went over, temperature instability and poor feeding. In cases of RH incompatibility, the fetal erythrocytes are hemolyzed by maternal antibodies. The issue here are the maternal antibodies. Okay, so we have a 34-year-old G1 mom who is a type 1 diabetic. She's been diabetic for 30 years. She was diagnosed at the age of 4. Which instruction is most optimal pregnancy outcome? Optimal pregnancy outcome. The correct answer is, so your concern with the type diabetic is, you have many concerns, but one of the concerns is that the will be vasoconstricted, and so this fetus is likely to receive less glucose and less oxygen. So the correct answer is monitoring for fetal activity, B. She doesn't need to be maintained on bed rest after 34 weeks. Restrict weight gain to 20 pounds. Her weight gain does not need to be restricted. Again, she's a type 1 diabetic and she's been diabetic for 30 years. Chances of her having a macrosomic baby are fairly slim. More than likely, this baby is going to be small and growth restricted. Monitor the urine for glucose. That is something that we will do, but it is not most critical to pregnancy outcome. The oxygenation, making sure that this baby is receiving adequate oxygen is. So monitor for fetal activity. This one, we talked about this one. Yes, we did. Did we talk? No, we didn't talk about the meconium. Okay. So pregnant woman admitted for induction at 43 weeks. So she's post dates with sure dates. So her dates are confirmed and she's definitely post-term. Non-stress test is non-reactive, which is not good. Amniotomy was performed. Thick meconium stained fluid was noted. Which of the following should the nurse anticipate? So this is a post-dates baby with meconium, thick meconium. So we are anticipating, what are we anticipating? A, meconium aspiration, hypoglycemia, dry, cracked skin. Dry, cracked skin. So again, thick meconium stained fluid was noted. So more than likely with this baby being post-dates, this baby has already aspirated some of that fluid. Hypoglycemia again relates to the post-dates, and the dry, cracked skin relates to the post-dates as well. The answer to this question was 24 milliequivalents. I think everybody got this one correct.
Professor,
Yes.
I had a keyboard mishap with this question. It was my last question. My time was running out, but before I could notice that I wrote 25 beside 24, my test ended.
I don't offhand, I don't remember if there was a 25. I think just about everybody, but I have to go by what was entered.
Okay.
We talked about this one, the overhydrated preterm baby. And okay, women who survive amniotic fluid embolism, so anaphylactoid syndrome, are a significant risk for which of the following? The correct answer was B, neurological impairment from severe hypoxia. So these, again, this is basically asking about a situation that's very similar to a pulmonary embolism. what are the risks? Okay, so neurological impairment from severe hypoxia. All right, there are no answers. So I am just going to
Professor, is it possible to have the opportunity to like see which ones I personally got wrong? I mean, I remember most of them, but there were a few I couldn't remember which answer I put because I was kind of going back and forth.
let me answer you in just one second. I'm just trying to find this question that I did not do, that I skipped somehow. Did that one.
This one, Professor, this one, a 32-week gestation neonate is NPO.
So in answer to your question, Victoria, if there is time, if there is time afterwards, yeah, let me just finish this. If there's time afterwards, then I can probably just run through really quickly with you, your own, on a separate meeting.
Okay, thanks.
32-week gestation neonate is NPO. So we have a preterm baby that's NPO in the NICU. The mom is asking about using the electric breast pump to save milk for the baby. So the most appropriate response is that you do want her to start pumping now, which is you want, the breast milk is going to be the best thing for this preterm baby to get the immunoglobulins and so on from that early breast milk. So you certainly want her, she wants to breastfeed, so you certainly want her to start pumping to stimulate milk production from now. So starting to pump now will help stimulate milk production is the correct answer. The breast pump will not cause engorgement. It will actually help with emptying. Yes, we have time because the baby is NPO, but if she doesn't start pumping, the milk production will not get started. So you don't, yes, you have time, but you don't really have time. You have time in terms of when the baby will be able to feed, but you don't have time in terms of the milk production. Breastfeeding may be too tiring. Again, this baby can always be tube fed.
Is NPO, so.
Yes, NPO now, but if the baby can't tolerate feeds, the baby can
later on, yeah.
Professor, there was a question about mastitis, and with one of the option as blisters. Did we talk about blisters on the lecture? Because I don't recall it. Guys, do you remember that? Because I don't remember that.
We talked about trauma to the nipples. We did talk about trauma to the nipples, yes.
So are the cracks in the nipples are the same as blisters?
Cracks to the nipples are not the same as blisters, but we talked about trauma to the nipples, and we did talk about appropriate latch and so on. This question is asking you about factors that contribute to mastitis.
Okay, thank you. And Professor, one more thing. Can you please discuss my exam with you too? Because I calculated less mistakes than my grade shows. If you have a chance, please.
So are there any other questions about the?
No.
Because I also recall reading that the redness was a sign of toxicity.
It's a side, I wasn't there when you, it's not a side effect, the hot flash.
It is a side effect.
Okay.
It is a side effect.
I thought.
Are there questions? So we only have about 20 minutes before Professor Britannico joins. So I know that there were some questions in terms of reviewing for the final. So I want to make sure that I'm able to answer those questions. So there are no questions for.
Oh, Professor, your chat is set to private, but I just had a question as to, is there a priority for, I mean, is there a specific chapter that we should focus on, or it's everything?
So the final is cumulative. The final is, sorry, I'm just responding to Professor Britannico. The final is cumulative. I will post the blueprint tomorrow. I don't know, I haven't really thought, to be honest, about what's on it because I was focused more on the midterm. So it's hard to say exactly what's on it. Technically, it is cumulative, so it's supposed to be everything. Which is basically impossible to put everything on that one exam. I don't know what to tell you to focus on.
Is there a way that you could be more detailed in the blueprint? Just to help us a bit?
I did say yesterday that I would narrow the categories more. Yes, for the blueprint for the final.
Thank you.
Please, thank you, Professor. We want to.
You're welcome.
Professor, would you be able to post up some Davis quizzes once you've decided what the content of the final will be? Or practice quizzes, an idea of, you know, like Jasmine said, what to hone in on.
I can try to do that later this week.
Thank you, Professor. Appreciate it.
You're welcome. I can try to do that later this week. Just write that. Okay. Okay. Let me just make sure I went through everything I wanted. Yes, yes, yes. Okay. Just making sure I went through everything that was on my list that I wanted to talk about for the review. Anything else that needs to be clarified as far as content or so on? Otherwise, we could take a break because I know, Professor Britannico, you're going to have to do a quick change in mental gears for her to join at 11:30, and I'm going to try to touch base with her to see if she or Professor Eng have any information about the tomorrow about the HESI. Okay, so
Professor,
so what? Yes.
Can I say only one thing about the toxicity? I check on my notes, and actually it was both diaphoresis and flushed skin on the sign of toxicity. And also on the side effects, lethargy, weakness, diarrhea, sensation of flushing, redness of face. So, but I found a question somewhere in all the question that I did. And so I erased from sign of toxicity. So that's why I guess some of my classmates are confused about this, the toxicity and side effect of magnesium.
Right. Okay. Well, as I said, I'll go back and
Thank you.
and I will look at it. I do have that on my to-do list.
Thank you.
You're welcome. So why don't we take a break now and come back at 11:30? I'll see if I can, I'll look at the,
Okay.
I'll see if, well, let me check with Professor Britannico. That's the first thing. But I will certainly look about the magnesium and I will get back to you one way or the other. So maybe at the end when she's finished talking to you about psych, not to kind of have your brain going backwards and forwards, but I'll try to get back to you as soon as possible. Okay.
Professor,
Yes.
I'm sorry, I missed your answer for my question. Will you be able to go over my exam with me?
So I'll have to look at the time. So I know, I think 3 of you contacted me. Let me look at the time. I have to get back to you.
Okay, thank you.
Okay. All right. So a short break and then so only 10 minutes. And then
Okay.
come back at 11:30 for Professor Britannico. I will be here and I'll see what I can update you on. Okay. And then we'll figure it out from there. Okay.
Thank you.
You're welcome.